lastly, we talk a little bit about patients who come in symptomatic. So, that can happen in the inpatient setting. It can happen in the ER. It can happen in urgent care, primary care, whatever. People say it drips, it burns, it stings, and I don't know why. And obviously in that case, you're using especially your differential diagnosis skills, trying to figure out, what exactly is going on and making sure that they get treatment so they can return to that optimal level of sexual functioning.
Let's talk a little bit about language. So you're going to receive throughout your career some conflicting advice about language construction and documentation and interpersonal communication, especially when you're talking about a patient population that might be stigmatized or otherwise systemically marginalized. But here's the principles of what we're trying to achieve. We want language that is not demeaning, not criticizing, stigmatizing, or looking down on the behaviors or identities of our patients. We know that everyone is doing things in their own best interest and trying to move through life the best way that they can. We want to reflect positive regard and towards our patients in our documentation. So some examples of how to avoid this sort of demeaning language are on the left-hand side of this chart, that deficits-based language. You can see how words like addict can negatively bias and depersonalize an individual we work with because of the stigma and the judgments attached to the word.
Stop scrolling. I'm going to talk to you about why you might be getting a yeast infection when you go to the gynecologist. One of the things I talk about a lot as a sex educator is growing our literacy about common ingredients that are in products we use every day, like lubricant. Now, if you've been paying attention over the last 10 years, there's been a major shift in terms of what types of lubricants are carried in grocery stores and CVS's. And the big difference is a change in one critical ingredient, glycerin. Now, glycerin is essentially just a type of sugar, and like most organisms, yeast that grows naturally in our vaginal canals love sugar as a food source. So the good thing is, as a consumer, you are now more likely than ever to see products like this that are glycerin and paraben free in your supermarket than ever before. Bad news, your gynecologist has probably not gotten the message, and more than likely you're getting your pap smears and pelvic exams with lubricant like this, which almost certainly does have glycerin in it. And your gynecologist has no idea.
Little kids have strange value placements that they get not from like the actual reality of what it's like to be a firefighter or a nurse, because like no kindergartner actually knows what that's like, but from what they see on TV and from what their parents say and from what the costumes look like in the supermarket for Halloween, because even creepy, like sexy firefighters look stronger and more powerful than sexy nurses do. And that's the messaging that is in our popular culture, despite the fact that like the reality on the ground is that both of these professions are equally crucial, important, and powerful positions.
So cultural competency was sort of the dominant term that we used in teaching about systemically marginalized communities for a long time. Is this idea that we're trying to learn about people who are different than us. We want to grow our knowledge about that community and our skills to interact effectively with them so that we don't act like jerks. The tough thing about cultural competency is when you're not part of a community, it's really hard to know all of the things that there are to know about that community. I make the example that, like, if you tried to explain nurse culture to someone who's not a nurse, there are so many in-jokes and like little references and nuances to the profession that are just not going to be accessible to someone who works in, say, accounting or in theater. I think of like our jokes about night shift or, about who goes into different specialties. And that's okay. We don't expect that of people. You can still be friends with a nurse without getting every single one of their in-jokes. So what's happened with our language is we're shifting to this idea of cultural humility, which is the sense that we don't know everything. We can't possibly know everything about communities we're not part of. So we're going to approach the situation humbly. We're going to acknowledge that we don't know stuff and we're always in the process of learning.
So two things. One, my favorite trend, and like I think one of the most valuable things we can do no matter what area of healthcare you're involved in, is like to really embrace these interdisciplinary conversations. I think the smartest, most interesting things that I have learned about what to do in my nursing practice have come from somewhere else, from pelvic floor therapy, from dentistry, from psychotherapy and counseling services, from harm reduction and like street-based medicine. There is almost always something unique that you can get from a practitioner who's operating in a totally different context, that will enrich your practice and make you better able to serve a much more diverse range of communities. And at the end of the day, I think that's what we want for survivors, because survivors don't owe a disclosure to their healthcare provider ever. And so we need to make healthcare at a baseline supportive for survivors, so that they don't have to self-advocate, they don't have to disclose in order to get the care they're entitled to.
So the hierarchy is kind of the spiritual heir to Gail Rubin's The Charmed Circle. In the Charmed Circle, there are types of sex that are considered societally privileged. They have a level of social acceptance, and there are kinds that are not charmed or not privileged and that incur a lot of stigma. The hierarchy takes this to another level when talking about sex work by sort of stratifying types of sex work and inherently types of sex workers in terms of how much societal privilege they have, what kind of access, what kind of safety, and what kind of approval they receive from the broader society. So at the bottom of that level are the full service sex workers, particularly folks who are operating out of doors. We sometimes talk about street-based sex workers, and those folks also tend to have a number of other intersecting marginalized identities. They tend to be lower socioeconomic status. They are often people of color. They may be undocumented, have other identities that are also not charmed. And we work our way up the pyramid towards the top, which is often situated with people who do not have any direct contact with their clients. So these are folks who operate phone sex lines, people who participate in digital erotic work, so cam girls or porn performers, where they have a lot of insulation from the violence that folks at the bottom of the hierarchy might experience. And they also tend to have a lot more societal acceptance. So we have much less of a problem socially, at least in the United States, with people who participate in phone sex than we do people who are out performing full service sex work where they're visible on street corners.